Good day, everyone. My name is Rebecca Kirch. Welcome to our webinar, Unifying the Field, Finding Common Ground on Navigation Policy Pathways. I'm in Washington, D.C. and work at the National Patient Advocate Foundation doing policy and programs. And I'm joined today by three colleagues, and it's my pleasure to introduce each now. I'll give some opening remarks and then we'll hear it from each of our panelists. But we have with us today Alan Balch, who is the CEO of both Patient Advocate Foundation and National Patient Advocate Foundation. We have Fran Costello, who is the president of the Patient Advocate Foundation. And we have our policy consultant, Becky Shipp, who is the principal of Becky Shipp Consulting and a longtime Senate Finance Committee Hill staffer who's been contributing expertise to us through our planning for this webinar and all that we're going to talk about today. We're thrilled to have you all here because it's been years in the making, the opportunity to think about how we can bring the field together and talk about the opportunities that we have in helping support what patients and families most need outside the context of the clinic. So that's our focus of this webinar series, which starts with an opportunity really to think about strategies we want to work with all of you to develop to advance what we're calling needs navigation to help support people's financial and social distress. We had an earlier webinar last month, very well attended, and largely focused on how many different roles there are that do this work. This webinar is focused on the opportunity to join together in that same spirit with discussing the policy pathways that help position these services of needs navigation as an important, effective, and essential solution to help solve the challenges we have with barriers to care for people in limited resource populations who are facing complex chronic conditions and desperately want to get well, but don't want to be financially devastated while doing it. I did skip over the welcome slide that had a couple of points as reminders. First, that we will be reserving time for questions and answers that you can enter in the Q&A box either throughout or when the presentations conclude, and our team will help to shoot those questions our way for responding. And there is an evaluation at the end of this webinar that we do hope that and encourage you to complete so that we can have feedback that helps guide us as we continue to share information about this initiative, but also opportunities for working together. So thank you. Next slide. I think where we'll start is sort of the aha moment of what needs navigation is trying to address. And that's the financial and social distress and devastation that patients and families often experience when they're facing a long-term chronic illness, a complexity of a system, complexity of disease processes. And we're sharing here this data from the population that the Patient Advocate Foundation serves. You're going to hear quite a bit about the details of our organization, but what I'll say to start, and then Fran will fill in some details, is Patient Advocate Foundation was founded to help support people who are caught in the in-between of clinical care and community care and the worries about their daily lives that go on in terms of financial, social needs. So what we do is provide services that help people find their way to and through the system, to and through health insurance coverage or other programs that help support them making the most of programs are available, insurance that they have. But we know that plenty get left behind, either because they haven't been fortunate enough to find navigators like some of you in the audience may be, and like the navigators we have on staff handling these calls by phone. We know that financial devastation is a top concern for the patients and families who are fortunate enough to land with us through referral processes because they have met with barriers that affects their ability to get access to care, affordability, adhere to their treatment regimen. And we know that for the patients and families that responded to our survey of just a couple of years ago, there was an overwhelming response about the fear of financial distress, even on top of dying or symptoms and side effects. So I think it's very important that we sort of have in the back of our minds the state of being that many limited resource populations are experiencing as they confront their complex chronic condition. And many of you know this all too well because you may be in the profession of helping navigate them through patient navigation, through financial advocacy, et cetera. So next slide, please. What we've seen through, I call this our logic model of sort of fundamental truths that we've seen through the services that Patient Advocate Foundation has provided, but also in the partnership work we do with the Financial Advocacy Network, with oncology navigators in patient navigation or nurse navigation, community health workers, social workers. All of you were pretty clear in our first webinar in agreeing that this is a job for all of us to think about how can we help support these huge gaps in the safety net that are exacerbating social determinants of health-related health risks and the inequities that follow. Because all of those distressors and the gaps in the safety net are impeding people's access, their affordability to care, and their ability to make person-centered, personalized decisions for them when they're already experiencing this sort of devastating distress and the disparities that we know and the COVID pandemic has only sort of amplified in terms of challenges that people are facing. So needs navigation, which is these financial and social services to help guide people to and through resources and support their needs by having a person to advocate for them. We're characterizing it, and I think all of you would, as essential support for patients and caregivers in these different limited resource circumstances to help address their financial and social distress. So many people use different words to describe this kind of care. And that's something I want to dig into today with our panel and the follow-up to today's webinar as opportunities. So next slide, please. Needs navigation came out of, necessity is the motherhood of invention. And what we know is now what patients face is when they're going through diagnosis, it can be a whirlwind of newness on top of their daily lives. And so the middle box here sort of describes, we wanted to paint a picture for what the life flow is for patients and families to describe how needs navigation fits in and complements with what clinical care and clinical navigation focuses on. So there's this diagnosis experience, which in its own right takes navigation to get yourself from having symptoms to being diagnosed, right? But then we think about all the direct medical costs and everything that needs navigation is really focused on the other half of the worries, which is the person in the middle saying, how am I going to make my life flow work alongside these unexpected new expenses, or even if they're planned, they can really take a toll on any household budget: food, energy, housing security, childcare, reducing your workload and resulting in lower pay. All of these worries are swirling as a constellation of concern alongside the clinical needs that you have. Enter needs navigation, as we're characterizing it here, and the support that it provides to deal with these worries of your everyday life, helping support this continuity of care across the clinic into the community. And for patients and caregivers, that typically means home or wherever they call home, whether it's a skilled nursing facility or otherwise, but the opportunity to have that support outside the walls of the clinic, the advocacy that's required. This isn't just steering people to resources, right? This is also providing that personalized one-on-one advocacy that people may need. And then helping people to feel heard and understood. There's a skilled communication to assessing people for their needs, sympathetically, empathically, sensitively, that avoids judgment and stigma and really helps support people in recognizing this is more common than you know. You're not alone. We're here to help. and there are different programs and resources available nationally in your community to help. So this is the swirl of needs navigation. Then we hope to help build the movement behind to make it a standard of care. Next slide, please. We did this little straw poll. It was quick and dirty, but just to get a sense, I've done quite a bit of work in the field of palliative care where we were working on an identity problem there where people didn't know what it was, but once they understood, they wanted it badly. We did a similar approach here with patients that we've served through a survey, just asking a bit about how many of you have even been screened for what social needs you might have or financial worries. And it's just a little bit of over half that said they don't recall having been asked anything about their financial concerns or needs they may have outside the context of their clinical care. But once we explain to people a little bit about what needs navigation is, though most had no knowledge about what these services are or that they could be available, once they heard a little bit about needs navigation as that extra layer of support to give them that advocacy, those resources, that direction for addressing their financial distress, they felt it was a very important part of care. So we know there's an opportunity here, receptor sites, if you will, to build public demand. And that's an essential aspect of influencing what happens in policy practice. So next slide, please. This is where it comes down to our messaging around what needs navigation is. And I'm loosely using that word as a placeholder, honestly. It's not pre-cooked because we may need to find a different phrase because what we know right now is there are many of you who are doing versions of what we're characterizing as needs navigation. They're reflected in this word cloud that came from our first webinar of the different types of people in the larger field who are supporting meeting patients' needs, whether it's clinical navigation, nurse navigation, and or needs navigation. Look at all the words that we use to describe the different types of people involved, the touch points patients could and should have for assessing their financial and social needs, but also helping to support the gateway to addressing them with response through an effective intervention. So there are many characteristics that are common among this larger field that unite us, but we are siloed by care setting, by different role, sometimes even by disease group. And that causes some barriers, both in terms of confusion and identity problems for the field as a whole, but also in terms of how we approach policy change. Because as Becky Shipp will talk about a little bit, we need to be thinking about a clear, consistent, steady drumbeat of messaging that has consistent terms, descriptions, and definitions of the different points of care that people need so that they know how to ask for it. And so that providers know their role in helping refer to these services and or provide them hand in glove style. So there's an opportunity to really boost that understanding so that we build awareness, both for public, for policymakers, professionals and health systems and health plans. And then we build the public demand, which is sort of the magic formula to policy change and really showcasing the field's influence together with patients, a patient-driven effort to make this happen. Term testing will be an essential step that we hope you'll all join us in being part of as we organize it through our Patient Insight Institute in the next few months to help focus group, work on the terms, do some public opinion polling, and really identify the language that resonates, that's patient informed. I think what has been a shortfall in other areas of trying to do this work is we sit in a room and try to define ourselves instead of getting patient input and caregiver input on that return to patient, as Alan will talk about, the return on investment for patients that navigation brings. So the opportunity to suss some of that out through some structured research will be a really important opportunity for us as a collaborative field to pursue. Next slide, please. So here we get to the strategy we'd like to share with you and involve all of you in that's really a moniker around socializing, standardizing, and scaling needs navigation so that it becomes available reliably for all people who are confronting complex chronic conditions in limited resource communities, so that it's available in every setting, and that we have a response that's proven, practical, and real and pertinent for all positive screened patients and families who are facing social risk that's identified through screening as a social need. Next slide, please. I'm ready to bring our panel to the discussion, starting with our CEO, Alan Balch. He will give us that big picture about why has needs navigation seen its place in the sun and what is our opportunity next. And so, Alan, I'll invite you to the screen and to the floor and to the microphone to walk us through a bit of the big picture about where needs navigation got its momentum and its roots.
Sure, great. Thank you so much, Rebecca. And I'll be relatively brief. I'll just do a little bit more setting of the stage for you, especially focusing on why now. You know, it seems like the moment has come. Finally, we've been doing this work, and I know many of you have as well for many, many decades. It's the work our organization was founded on. We call it case management, but it lives under a lot of different nomenclatures, as Rebecca already alluded to with the word cloud. Next slide. I think just seeing the background of a lot of the folks in the room already, I won't linger too long on this point. Rebecca already hit on some of the high notes anyway, but I think it's good to remember that the healthcare system, including patients, they often focus when they're thinking about their healthcare and their engagement in the system with the clinical aspects of care. Even our concept of health literacy focuses on the clinical dimensions, and our concepts of shared decision-making often gravitate to the treatment options and the clinical care. And so that's the world on the left here in this diagram, but and sort of the sort of what happens in the community and what happens to patients, sort of considered out of scope, is something that maybe need to be addressed once patients are in treatment and run into barriers. But there's sort of this idea that patients come into the four walls of the clinic, and their main vehicle for entering the system is really their healthcare coverage. That's sort of the gateway into it if they have that, and then they go back to their homes. And that what happens outside the four walls is kind of external to the system. And I know many of you don't live that experience. You're working in that crossroads, so that's not what your experience is. But I think generally speaking, this is still how the healthcare system is oriented. Next slide. But this is the reality of the lived experience that all of us know very well, that these aspects of the living, what happens when people are back in their communities or just getting to and from care, is much more complicated than just their insurance coverage, and includes all these things and more that are the social determinants that in part drive health inequities and health disparities. Next slide. And this is not limited to any particular diagnosis. Obviously, the more complicated and the more movement and interaction any one person has with the health system in terms of their clinical care, the more likely one or more of these things are going to surface. And the longer someone's in care, the more opportunity there is for these things to get in the way. The good news is, I think there's if there's a silver line to COVID, it just and other things that happened over the last few years, it really has shown a bright light on the need to address health inequities and disparities, and really the mechanism of action there is really addressing social determinants, at least in the healthcare system context. And so what's happening, and the good news is that health system is starting to, for lack of a better word, clinicalize or internalize this problem set through screening. So I don't know if you're aware, but pretty much every stakeholder in the system is running in some way to some degree of screening for social needs. The health plans, the pharmacists, pharmacies, both retail and specialty, obviously the nonprofit advocacy community, the hospitals and clinics themselves. So that's ramping up. And of course, there's going to be quality initiatives and measures associated with both screening for and addressing health social determinants. And there is, if you go to the next slide, there is a Z code system that actually gives the ability to diagnose this set of issues and problems that patients have. We at PAF have a coding system of our own that tracks about 170 different types of issues. The Z code system is not yet that granular, but it's heading that way. There's a 10 coding system that's there's a lot of efforts to expand it down to the 10th and 100th digits to get to really specific problems like utility shutoff, for example. So if you're not familiar with Z codes, that's a whole other conversation, but it really is this idea of being able to diagnose a screen and then diagnose someone with a social need. And that's wonderful, except what do we know about what we know about screening and diagnosis is it creates an obligation to treat or to intervene. And I think that's where we can ramp up a lot of efforts to scale and standardize, and we should, screening and diagnosis, but we also need to do the same for the intervention, because that's honestly the most important part. And you are all, for the most part, interventionists, so you know that that's at the end of the day what patients really want and need is not just to know they have a problem, but know what are you going to do about it. And that shows up time and time again in our own survey work when we ask patients, what do you need? Next slide. So we feel like, as you know, the safety net world is very complicated. It is siloed. There really is an opportunity to unite around a common set of services and definitions around this service, so that it becomes less complicated and more manageable for patients. It's the least we can do. So next slide. So what we're talking about here is really taking those social determinants, right, and filtering it down to really defining a set of social needs upon which we can intervene. And there's a set and a scope of work and a standard of practice and service that can address a set of issues that at the end of the day are about what's the benefit to the patient. And I think that's the key here. Different stakeholders will define the benefit in different ways, depending upon both the patients they're serving, but also, let's be honest, the financial benchmarks and needs that they have, which is fine, but that then does start to limit the scope and the focus of the activities beyond just, from a return to investment kind of approach, rather than what's the benefit to the patient. I think we really have to define, at least normatively, the standard of practice and the scope of service by what's in the best interest of the patient, regardless of the stakeholder or where they're being served, or what's the best financial interest of the person providing the service. Next slide. So I think the idea here is, how do we scale that work? We know we've scaled and we still have a lot of work to do around the patient journey from a diagnosis perspective, and there's lots of navigation work to do in that space. But then all this stuff in the middle, that's the problem set that we're talking about, scaling and standardizing a solution to in this context. Next slide. So needs navigation done successfully and done with the patient at the center really moves us towards health equity. It provides greater access to resources for the patients and the care they need. It gives us better understanding of the experiences and preferences that patients have. And it ensures that what's most important to patients, especially low-income vulnerable patients, is discussed early and often and addressed in the patient journey. Next slide. So I'm going to turn it over to our president of operations, who's going to really drill down a little bit into what it really means, at least for PAF, to provide this work and this service, because at the end of the day, the issues and ideas we're talking about here are things that we've had experience with for more than 26 years now, and we have a dedicated team of 35 to 40 individuals who provide this type of work every day, all day, for tens of thousands of patients across the country in all sorts of different diseases and geographies. So go ahead, Fran.
Thanks, Alan. I really appreciate your setup there. So thanks for having me on today. And as Alan said, I'm going to talk a little bit about Patient Advocate Foundation and how we deliver case management in an effort to address some of the social determinants of health that people experience, with really the goal to improve their health outcomes by addressing some of the practical issues that they face. For those of you, I think most of you probably know a lot or know something about Patient Advocate Foundation, but in the case that you don't, I just really wanted to start by grounding you in our mission, in our history. It's similar to the work that a lot of you do. We really want to be a problem solver. We were set up to provide case management services and financial assistance to people living in the US who are experiencing a chronic, life-threatening, or debilitating illness and are having some sort of access or affordability challenge. When we started it back in 1996, it was out of a very personal experience. Our founder, Nancy Davenport, is helping a dear friend of hers who had late-stage breast cancer and could not access the health care that she needed, and very quickly realized the importance of solving coverage issues, travel and transportation issues, end-of-life issues, became to making sure that Cheryl had the best health outcome that she possibly could. Since that time, since we opened our doors in 1996, we've served more than 1.7 million people. Those are people that we documented, that we talked to, that we worked with, either through our case management services, which I'm going to talk about today, or through one of our financial aid programs. Next slide. So a little bit of statistics for you. Just in 2021 alone, we served about 150,000 people. I'm going to hone in today on the 20,000 people who were served through our case management department, which is really where our social needs navigation work lives and breathes. Outside of that, we have other very complementary programs providing direct financial assistance. Some of you may have interacted with both our copay relief program, as well as our small grants programs that cover non-medical expenses. Next slide. So let's talk a little bit about what we call case management. Rebecca's word cloud was like so apt. We hear different terms and different definitions of case management. It means different things to different people, but for PAF, it really means being that connector and being that doer between the patient and their families and the systems that they need to interact with to solve problems that are impacting their access and their affordability. We do that across all disease states. As you can see here, these are just our top 10 diagnoses. We tracked over 700 unique diagnoses in 2021 alone in our case management department. This program, ironically, does not have an income or means test, which I know many of you, especially those of you in facilities, likely don't either. But what we tend to see are lower income folks with very complex health conditions. It's a very hands-on delivery model, average of 16 contacts per case. It is not something that is, a one and done, where we can provide a few phone numbers and hope for the best, because usually the outcome there isn't good and the person hasn't made any progress or hasn't solved the issues that are before them. It really takes a lot of hand holding. I kind of like to categorize people into three buckets. They either want us to point the way for them, and that happens for a handful of patients and families. They really just want to have that information. They want to do it themselves. A lot of people want us to show them the way. We want to find the resources. We want to go with them down that path and really help them connect, kind of drop them off, if you will, to that next point that's going to help them. And then some people really need us to take them there. They really need us to handhold. They need us to fill out the applications. They need us to give them advice and counsel, and we will do that as well. But it's just, I bring that point out because there's lots of different ways that we can propagate or perpetuate social needs navigation or case management. And we really got to meet the patients where they are in order for it to be successful. Next slide. So who do we serve? Probably similar to some of the patients that you serve. This is kind of a profile of 20,000 people. If I aggregate it down, 51% were aged 56 and older, which is always startling to me. It means half of the people we served were under the age of 56. We've continually seen that age number come down. COVID definitely had an impact on those that are working and their benefits are tied to work and the job loss that they experienced. 47% were living at or below 250% of federal poverty guideline. That number goes way up if you move up just to 350% of the federal poverty guideline. And we don't have an income criteria. That's not an eligibility requirement to access case management services. But obviously those that are more at risk financially already have much more trouble paying for cost of living as well as their medical expenses when they're faced with either a critical illness suddenly or the long-term effects of a chronic illness. 66% were female, 89% were insured, which means 11% of the people we served in case management did not have any form of insurance. They typically fare the worst and have the greatest financial needs and the most access barriers. So the number one thing that we want to do in those cases is help them find insurance and see if that's an option for them. Often people think it's not. With the marketplace, it might be. We just have to figure out what plan is right and how can they pay for it. 65% were retired, unemployed, or disabled. So lots of folks on fixed incomes or already very financially fragile, but 35% were full-time employed. So it's really, it doesn't discriminate. Some of these social determinants and social needs that people have really transcend some of these criteria or some of these, profiles, if you will, of people along those lines of employed or age or disability status. 40% were from a racial minority group. And the top diagnoses out of that 700 plus that we saw in 2021 were cancer, COVID-19, diabetes, cardiovascular diseases, and MS. Next slide. So what did patients need from us? Much like the needs that they have and they express to others of you on the call, help with their healthcare costs, paying for utilities, housing, transportation, nutritional needs. Lots of folks needing help enrolling in disability because the process can be very difficult, but it's an important one because if you're approved, it starts the clock on Medicare. It also gets some income into your home, and then help enrolling into insurance. And that's both the uninsured and the insured population who are trying to make sure they're in the right plan, or they may be at risk of losing insurance due to a job change. Next slide. And what were we able to do for these folks? So obviously, you need to see a correlation between the issues and the resolutions, which you do here. Obtain financial assistance with utilities and rent, facilitated connection to resources to help with transportation needs, facilitated financial assistance or applications for assistance for out-of-pocket medical costs, medication costs as well, negotiated directly with providers in some instances to get discounts or payment plans for outstanding medical bills that were at risk of going to collections. Did a lot of education about disability, as well as assisting with enrollment and follow-up if they had already started that application process, and then educating about the health insurance options that might be available to them, or reviewing the plan they're already in during an open enrollment period to determine, is that really the best option based on your current health status today? Do want to point out, Alan mentioned it, we track over 170 unique needs or issues. So these are just the top ones. Anything that gets to 6-7% is pretty significant in our data set because of the number of issues that we track. And most patients that we serve have more than one need that we're working on concurrently. Next slide. So I'm not going to read this because I think this information will be shared with you following this webinar, but just to know, where our help really kind of lands or lines up is in 3 areas: reducing financial burdens that people have, helping them enroll into appropriate insurance, charity care, or social programs. And then for those people that are insured, having them, helping them navigate their insurance plan, because the fact you have insurance does not necessarily mean that you know how to use it most effectively. Next slide. And I want to close with a case study. So how were we able to help people in real life? So this particular patient that we served, she had insurance. She came to us recently diagnosed with breast cancer, was about to start her treatment, and was notified that her employer was going to be selling their company. The new company was not going to be offering health insurance. They were going to let them go buy it on their own. And she had about a month to figure out what to do next. So you can imagine her alarm. She had been to the marketplace. She did not think she could afford the healthcare on the marketplace. And so she called us to see what we might be able to do. Next slide. So I think this is just so indicative of most people that we work with and most people that have challenges along these practical lines, which are most patients, quite frankly. They have an immediate need that makes us reach out to an organization like PAF or to a social worker within their hospital or a financial aid counselor, only to find out they have lots of other things that they need help with. So we were able to help this person enroll into a marketplace plan with the benefit of a subsidy, reducing those out-of-pocket costs both monthly and across the whole year. Again, she didn't think she could pay for it. I was really pleasantly surprised that she could. So we resolved that coverage issue, but we also were able to talk with her after hearing some of her other needs about how to talk to her employer about FMLA and accessing the short-term disability policy that had intermittent leave or intermittent disability benefits, coordinated some other financial assistance that we knew about, a transportation grant, a copay grant, as well as a couple of local financial aid grants from breast cancer foundations to cover practical things like some utility costs and some outstanding medical bills that she had. And I just, this is just can't stress enough the value of this kind of help. We cannot do it alone. We're not trying to do it alone. And I think that's what this call is all about, to say, how can we continue to collaborate and bring some standardization and some unification to these efforts so that ideally one day all patients, but at least patients with certain diseases can access this kind of help in a timely manner, and they don't have to hunt for it or be the lucky one that gets in with a social worker when they're hospital or finds PAF's phone number. I'm just going to close out with our contact information. So if you have somebody that needs help, you can refer them to our phone number. You can do a warm transfer and drop them off. You can give the phone number out if you'd like. You also can request help using our secure online intake form that's available on our website. So thanks so much, Alan. I'm going to hand it over now to Becky Ship, who's going to talk with us a little bit about the potential policy pathways that we may have to bring some standardization and scale to needs navigation.
Thank you so much, Fran. And thank you everybody for being here today. And thank you for all the work that you do to improve outcomes for patients and their families. I'm here today to talk through a number of various policy principles to advance the goal of improved access to care. Next slide. I'm pulling up this slide again. You've seen it before because it really was a light bulb moment for me when I realized viscerally that more people fear the cost of treatment more than they fear dying. And it really just underscored to me how critical the imperative is to improve access to needs navigation services. When I talk with folks on the Hill, I generally lead with this, and it is a showstopper. Next slide. All of these issues for me were reinforced when I got the wonderful opportunity to visit the Patient Advocate Foundation in Hampton. I was deeply moved by PAF's origin story, people helping people go through this disease journey was very compelling. It was my privilege to meet with and see the work that tireless, dedicated caseworkers underwent to assist those lucky enough to find PAF. And I'm emphasizing lucky because it was then another light bulb moment for me when I realized that PAF and the need navigation services they provide is one of the best kept secrets in healthcare. Next slide. See, I worked for over 20 years, as Rebecca indicated, on Capitol Hill, and much of that time spent on the Senate Finance Committee doing health policy. As some of you may know, the Senate Finance Committee has jurisdiction over all of the federal entitlement programs, Medicare, Medicaid, CHIP, and welfare programs. I was deeply entrenched in every piece of legislation that went through the health policy division of the Senate Finance Committee for many years, and I never learned about the need for navigation services. I've since followed up with my former colleagues on the Senate Finance Committee, as well as the House Companion Committees, Ways and Means and Energy and Commerce, and they are also unaware of the critical need for needs navigation services. They do persist in the belief that the issue has been addressed by insurance reform and other regulatory initiatives. What we need to do is educate the Hill on the fact that if patients and caregivers don't know about these insurance reforms, they won't be able to avail themselves of them. Next slide, please. I'm driven by, and we need to educate the Hill on what I like to think of as our North Star, which is that needs navigation services must be a standard of care in the United States healthcare system, and it needs to be readily available to all patients and caregivers in all care settings. This is, as I said, our North Star. The approach that we are undertaking in terms of our policy pathways is focused on the Senate Finance Committee and their companion House committees, the Ways and Means and Energy and Commerce committees. Why are these committees, why are we focusing on them rather than a reimbursement strategy? Well, to begin with, the two are not mutually exclusive, but we're focusing on these committees because of the old joke when a bank robber was asked, why are you robbing all of these banks? The answer is, well, that's where the money is. And to be candid, the Senate Finance Committee and the companion House committees, that's where the money is. That is because, as I indicated, they have jurisdictions over the entitlement programs, which comprise the bulk of funding that the federal government spends on healthcare. And once entitlements are amended, generally those policies become permanent features of the statute, unlike authorizations, which depend on the yearly appropriations process. Next slide, please. I'm going to outline 3 policy pathways that were developed to align with the jurisdiction of the Senate Finance Committee and the House committees. These are enhancement, flexibility and innovation, and expansion. Next slide, please. Enhancement pathways explores current legislation and tinkering around the edges of existing programs, such as allowing broader use of certain block grant funds to improve access to navigation services. Next slide. Flexibility and innovation. Increasing flexibility and innovation contemplates working with states on a number of policies that will enhance innovation, such as certain waivers, certain state plan amendments, and demonstrations to improve access to navigation services. Next slide. Expansion is focused on expanding the use of entitlement funds to improve access to navigation services. These pathways are not mutually exclusive. They can all work in tandem and can also be advanced around authorization efforts, reimbursement efforts, and administrative actions. It's an exciting time to be engaged in these efforts moving forward to improve healthcare and outcomes for patients and families. I'm pleased to join you all in pursuit of these important goals. Thank you so much. I'll turn it back now to Rebecca.
Thank you, Becky, Fran, and Alan. Very grateful for the discussion. And I want to just tee up a couple of follow-up points, in particular on this notion of if social determinants of health right now are a hot topic, and it is, advancing health equity, and we're grateful for that. We have an opportunity to be thinking about as a field, joining together to make sure that our message on behalf of patients and families message on behalf of themselves sort of leads the charge here. So Alan, I'd love for you to expound a little bit more around the importance of this and the importance of the messenger being a patient-driven initiative versus health plans or other stakeholders who also have their skin in this game. what are some of the challenges we need to be aware of, and why is it important for us to stay out front?
Having some technical issues here on my side.
You're here now. We can hear you.
Okay.
Thank you.
All right, sorry about that. Yeah, I think, well, so I think there's a lot of different ways to think about who does what work. So, you know, obviously there's work that's done by those with clinical backgrounds and expertise who sit within or closely aligned with the clinic or the healthcare system, specifically clinical social workers, you know, nurse navigators, et cetera. And that's an important body of work. And I think there's another group and another important body of work that largely, while it may have clinical aspects to it, is really more sitting outside that domain and thinking about, you know, that intersection between the community and the clinic, and really linking people back into community-based organizations and looking for those resources and support within the community, or at the, you know, at a higher scale. You know, there's certainly state and national level support systems available, but really thinking about, you know, the focus specifically on the patient. People, you may refer to that as patient navigation, but I think even here we're thinking more specifically about those who address the social needs of those patients as they're returning to home, as they're returning to work, as they're moving back and forth between the clinic. And I think it's for those of us who do that work every day, it's really important that it be defined, you know, by patients and those who advocate on behalf of patients every day.
Thank you, Alan. And Becky, I just want to elaborate on this point a little bit in terms of the Hill perspective, that health plans are interested in what they can do as our health systems in screening for social determinants of health risks. Alan talked a little bit about the Z codes and the momentum there. In terms of the credibility in the eyes of Hill staff and those that we would partner with in the administration, like CMS and CMMI, what are your thoughts on the influence that patient advocates together with providers of navigation services have versus momentum that might be coming from insurance plan and others who have different motives for the type of screening intervention they might provide? Do we have an edge in the patient sphere?
Absolutely. I think, you know, given the emphasis, and, you know, the folks from CMS and CMMI have publicly indicated the need to hear from patients as true clients of the system. The social determinants of health issue that Alan spoke of, as well as the emphasis on health equity issues, is really driving a patient-centered approach to improving our healthcare system. And in that case, you know, PAF and NPAF and all of you really are the front lines and critical, and a significant edge to advance our needs navigation agenda.
Thank you, Becky. And now just a quick question, but an important one for you, Fran, because Sharon Gentry very graciously posted the oncology navigation standards that have been developed very thoughtfully and carefully in the nurse navigation world. We don't have anything like that yet in the context of needs navigation, but we know that that's an essential hand in glove relationship. What do you think are some of the key aspects of work that the field needs to come together to do to start to build understanding and consensus around the core competencies of this needs navigation that's an important supplement to what patient navigation has been in the oncology context, nurse navigation in the oncology and beyond context as they're spreading their wings to more chronic illness like what we are supporting with the needs navigation side. But what do you see as valuable next steps for the navigation field in total to join forces around doing to sort of bring us to that same place of standard building? we just need to take you off mute somehow.
Okay, sorry about that. I was just saying that's a huge question.
Yeah.
And with lots of different options, but I think priority number one probably is doing what we're doing now and bringing together advocates, navigators, case managers, leadership of those kinds of activities from different disease groups, from different health systems, and having real conversations about what is needs navigation. You touched on it earlier, from the perspective that there's so many different flavors of help. I think that's the best way to say it, that are being done at the local level, at the facility level, at a national level, all of which are very, very helpful and meaningful to the person receiving those services. But they're not always as coordinated as they could be, meaning we don't always leverage each other as well as we could. And there's no consensus or standards that exist that say, okay, each person that has cancer, or every person who has diabetes, or every person who has fill in the blank, really deserves access to a professional that meets XYZ standards and is going to deliver A, B, and C to them if that's what they need. That's a big lift. And I understand what I'm saying here would take a tremendous amount of effort on the part of a lot of really smart people. But I think that there's enough energy to do it. There's enough support to do it. And Alan pointed out the screening tools that are being introduced with great regularity. You've got a lot of, tech companies that are in the middle now between us and patients, and providers and patients, gathering lots of insights and information that I think we could hone pretty quickly in on the what we need to be doing for patients. It would then be figuring out how do we do that. So I hope that answers your questions. I know it probably sparks a lot of other thoughts and comments, and it would take lots of different work groups and working in parallel, and then working together to share, kind of best practices, and what would the framework look like for a standard needs navigation, case management, TBD name program to be embedded in our health systems and beyond.
Yeah. And that, just to be clear, that's not to say that that other types of navigators, clinical social workers, clinical nurse navigators, are also doing some of that work. But increasingly, a lot of that work, especially defined by that problem set of social needs and social determinants, is going to be done by those who are working at the interface and in communities, or serving communities, and not just patients, right? Patient advocacy groups. But think about the work that's now being done by the health plans and the pharmacies, and especially pharmacies and other actors in the system that are now not just doing the screening and diagnosis, but are also deploying different types of services, case management, navigation, not just around the clinical domains, but around these social needs. So there's a much larger universe, not only do you have a need to think beyond just a disease, but also to think beyond sort of the clinic and advocacy groups, to expand the set of stakeholders here to include, that village of people who are now doing this, are starting to do this work and paying close attention to the needs of the most vulnerable patients, and not waiting to provide services until patients fall through the cracks or till they haven't picked up their prescription, but actually going out into the community and sending people to people's doors. How are they, so they may have a completely different training and background than what we typically think of, but they're going to be doing that work whether they're committed to doing that work. And so there's an opportunity to think about how to unify a broader set of stakeholders here, not just by disease, but by different types of actors in the healthcare system, but the commonality is that they're all trying to work that problem set of social needs, and most of the solutions are not necessarily found in the clinic, right? They're found in the community. And so really those individuals who are going to be best positioned to link patients back to resources and opportunities and help for that broad set of needs within their community and beyond.
Thank you all. I know that we have some questions stacking up, which I'm grateful for, and I want to turn to now, and our team will help us know who they're directed to so that we can turn to that. But I'm grateful for what I'm hearing from each of you, and I know we're all feeling is this inertia now to join forces together. That's something we heard from the last webinar. Again today here, the opportunity to bring to the community health workers, the social workers, the clinical navigators of different types, together in the room in a patient-driven initiative that helps give that credibility, as Becky highlighted, I think is significant. So team, can you please let us know some questions that we've got up?
Absolutely. Thank you, Rebecca. We have one question maybe for Becky Ship and Rebecca around Medicaid. How does Medicaid expansion or lack thereof affect needs navigation now and policy pathways to scaling needs navigation in the future?
Rebecca, if it's okay, I can take a first crack at that. As we indicated, our entire strategy, or a significant portion of our strategy, is focused on the entitlements. Medicaid is an entitlement to states around certain services and certain individuals. There is a provision of the Medicaid statute called targeted case management, which allows navigation type services to be available for certain populations eligible for Medicaid. One of our policy options that we've discussed internally is to explicitly, allow targeted case management and other types of facilitating services funded through Medicaid to be reimbursed by Medicaid for those specific services. There's also been interest in folks that have, undergone long COVID symptoms that need these types of services as well. So we are being very entrepreneurial in looking at all aspects to improve access to need navigation services. Excellent question.
Okay, and we had one additional question. Rebecca, maybe you can just elaborate. From Tony K. She says, always glad to share my family's story and struggle. Question on one of Rebecca's slides regarding the reference to all complex chronic conditions. Is cancer considered a chronic condition at this time?
We sure hope and pray that it can be for many. It can be an acute condition. It can be a complex chronic condition. In all its form, cancer is very much on the minds of needs navigators, just as it is for patient navigation, where the oncology field, very entrepreneurial, built a whole field of patient navigation and oncology nurse navigation. So they across the board, but that's not an official clinical moniker. It's just a description to say that we're inclusive of all diagnoses that involve long-term support needs and financial distressors. Tony K.
All right, that wraps it up. I don't see any other questions at this time.
Great. Well, we're just coming up on the hour, so I'll just ask to go to the take action slide if we could, Melissa, to close us out with our gratitude for all of you tuning in and for our panelists today to be here. We're excited about the prospects of this agenda. And when I have my gut check with Becky about, is this something we can really do on the darkest day, she will say, yes, we can. She has fire in her belly. I think we all do. We've been at this for many years. Fran and Alan more so than me. I've been with PAF for 6 years, they for longer, but what we know is that we've built this learning laboratory and the opportunity for collaborative extensions of all of you who have similarly built learning laboratories providing these services. We do want to join forces because that is the way we seize the momentum, that we see the opportunity. There are receptor sites in CMS and on the Hill for talking about what we do. And so we are providing in the link, the chat box, the links to 3 opportunities that we hope you will consider taking action as a next step following this webinar, in addition to filling out the evaluation questions when you close out. First, for all of you who are individuals who care like we all do individually as people, as humans, in helping support patients and families, sign up with NPAF to be an allied partner of ours, part of our grassroots workforce for good. Sign on if you're representing an organization or have influence with your organizations to be part of the statement of principles. Becky touched on the North Star. Those are the first 2 of several principles that sort of our organizing framework for pulling the field together around opportunities for consensus building around these policy pathways to start that coalition movement happening. And third, we hope everyone will commit to participating in whatever form your time allows, but it can be very simple and straightforward, but very impactful, to be part of our health needs navigation campaign, which is largely about spreading the word, introducing us to community organizations and patient advocacy organizations or others who you think would have an interest in being part of this movement to make needs navigation a standard of care. So in the chat box, we provided links for that take action opportunity in each of these for individuals, organizations, and everyone. I do want to thank especially our panelists and the NPAF team, who are our production team behind the screens, putting this together today. We will welcome your follow-up. There will be information coming to you for opportunities to sign up, sign on, and commit. And my email will be included there, and my phone number, and I will welcome anyone's comments or thoughts. We look forward to meeting with all of you in the next phase, and we're very grateful for you joining us today. Thank you.